Yes, hello. George Swan is my name. We're going to talk about hospital benchmarking today. If you've been following this series on how to benchmark hospitals, this will be looking at the California hospitals data sets and how to make an executive profile. In particular, look at some possibilities with pivot tables. This is a series of deep dives looking at various aspects of hospital benchmarking, and this one is about the executive summary, how to do it. We're looking at a hierarchy of holons here, just recognizing that the hospitals, clinics, physicians, sometimes we just get so engrossed in our institutions that we forget that we're all part of a bigger industry, and we work within communities, and communities constitute countries. And to the degree that the countries report to World Health Organization, OECD, GCC, the underlying rule is that countries cannot report to World Health Organization without data from the hospitals and physicians. And that's what we're interested in. Does the data get reported in a timely manner, and also in a comprehensive and a thorough way that serves all of us, actually? Just to mention the balanced scorecarding, it really is about patient engagement, employee engagement, and community engagement, and we need the underlying data to be engaged with is the financial KPIs, operational KPIs, clinical quality KPIs. And to do that requires that we think of data integrity and accountability. That means empowering our department heads and ensuring that we have some quality control processes. And it is a juggling responsibility, a juggling challenge. So, I know how to juggle. I teach people how to juggle, and it's not always easy to get it, but once you master it, it really makes a big difference. So I worked with Saha. Saha was the Abu Dhabi Health Services company, and this is an example of a consolidated budget that we did for the Director of Finance. We looked at 5 years of history, and we had a projection of 5 years. It's called a rolling five executive summary. The executive summary is made up of the individual hospitals and represents the big five, what we call the big five: the patient utilization, staffing, expenses, the revenue generated from services, and all the calculations and ratios that we can do. So, and we'll look at this a little bit more deeply. This is an example of a side-by-side for 2011 actual results, and it's the same big five, but it's side-by-side looking at every hospital, and it just, comparing, we can compare the hospitals, but we also require the hospital raw data to add up to the consolidated corporate office. And how we do that is really the subject of this video. And just, I was talking to somebody at the HIMSS Analytics. They require some input from all their chief information officers, CIOs. They want to look at how IT departments compare. To do that, they need basic data, and this looks very similar to what we would call the big five. If they had all the big five data, they wouldn't have to ask their CIOs to get this data collected from their hospitals and then bring it together in some more useful format. They should be able to get this information from the hospital licensing authority of any country, any community, any region. And it's just not as easily available as you'd like to think. This is an example of a PDF file from the Ministry of Health, the Northern Emirates, where I've been working for a while. And again, we want all this data. We want a list of the hospitals, number of beds, the utilization information. We also want to get all the other big five data. When it's in a PDF format, it's very difficult to use. I mean, we'd have to transcribe this data into some kind of an Excel sheet. And, why would everybody have to be able to do that? Why doesn't the Ministry of Health just make an Excel sheet available with all this data, not just for 2013, which is this data, but all the historical years as well? That's a good question to ask as we go forward in this exercise. Countries do have data warehouses. I would just challenge you to go on to any of these, Scotland, Canada, US, Australia, UK, and try to find a simple list, the basic raw data of all the hospitals in these countries. It's just going to be much more challenging than you can imagine. Vendors have data warehouses. Some of these, Dr. Foster's in the UK, the University Health Consortium of 180 universities in the USA, Colorado Hospital Association is part of a data bank system that's got this data, but you can't get to it because it's proprietary. And we should have a basic public information. We'll talk about cost reports in the USA that are mandatory for all hospitals. And, again, how easy is this? This is the American Hospital Directors Directory. I went in and found the Cleveland Clinic. I've got a map. I've got some nice information about the clinic. You can buy their data set and do all kinds of analysis, but you can't access their data without buying it. It should be available, free, from all of the hospital authorities, the licensing people, of the communities, states in the USA, Emirates here in UAE, and certainly by country to report up to World Health Organization. And Joint Commission, they've got information on all of their hospitals that are accredited. That means in the USA, all hospitals. And yet you cannot get a simple Excel sheet of all the hospital data, just addresses, contact information, basic raw data like number of beds and census and how many discharges and average length of stay and all that sort of thing. It's just not available. Not to mention all the clinical data that they have for core clinical information, but that's another video. The American Hospital Association, you can buy their proprietary data sets for an annual survey fee of $6,000. It's just not fair. I mean, this AHA should be making their basic raw data available to download for anybody that needs to use it. Why should everybody be doing the same different thing? It should be done by one licensure authority. End of story. So we're going to look at the California system, the Office of Health Planning and Development. And the first thing you can see is, when you go to their data, their website for data, you can see this nice little mind map and click on any of these these are all hot links into different outcomes. Financial is the one we're going to look at. And we're just going to go directly to the internet right now and see how this works. So here we have the hospital, different types of data, reports, tables, financial, and we're going to go to the financial website right off the bat. You can see how all the kinds of information, these are all Excel complete data sets that we can look at. And here's the charge master, for example. We really want trend data. Hospital financial trend is the one we're most interested in. They've just actually started this one. It's a wonderful data set. Imagine looking at hospital trends of bed occupancy rates. If you've got enough data, you can click and filter and select and sort and to your heart's content. So we want to bring up the hospital trends, the Excel tables like this. Just see what happens. I think this is going to bring it up. I wanted to bring up the raw data to begin with. Let's see. It's a little bit harder than I expected. Well, this is what you get. And you will find out that this is not formatted as a table. I will give you a clue right now. Whenever you look at, if we look at this, we have hospital characteristics, financial. They've done a lot of work with their data. They even have a pivot table here. So if you want to select, for example, a particular hospital, I picked Stanford because I'm interested in them a bit. And then you can actually look at some comparative data. They've got a lot of information here, but sometimes it's already set. This is a fixed table, and so as you click around and look at some of this, sometimes it comes up and it's not available. But here you've got different quarterly information. Let's go to something a little bit easier. I'm just going to expand that a little bit. Go back to this data. One of the things I like to do is just show these field names. This data, you can see, just goes on and on and on and on and on to the right. There's a lot of data there. Well, to make the fields a little bit easier to read, you just go into here. All I did was just copy the top rows, right click, and paste special, and I just transpose it. Here's all the data. So every hospital has all their contact information, and then you can see they've got occupied beds, number of beds available. You go a little bit further, you've got adjusted patient days, you've got total of discharges, you've got discharges broken down by all kinds of like payers, different bed types. So you've got acute beds, psychiatric beds, you've got these are bed days, inpatient days, nursery information, how many bassinets there are, visits, outpatient visits. Here's your outpatient rooms, how many surgical cases. I mean, this is just a wonderful, wonderful bunch of data. They've got expense information here, gross revenue, net patient revenue. You've got, if you go a little bit further, you've got information like, what is this, expenses, whether the expenses, what area they're in, ambulatory, ancillary. This is kind of an activity-based costing sort of system. And over here we've got hospital FTEs, productive hours. If you divide that by 2080 hours per year, you get the number of hospital FTEs, paid hours. You've got all the productive hours broken down by type of staff, and down at 254 data points. That's just amazing. And so if we go back to this this data right here, once it's in a table, when you format it like this, you actually have access to a table tool, and you can just summarize this with a pivot table like that. And if you want to make a list, for example, of the health facility names like this, you've got a list of every hospital in California. If you want to look at the counties that they're in, you could take the county name, just add that overhead like this. If you want to put the county up into a little select field, you could click on that, say, give me just the Alameda County hospitals. Now you can pick the kind of data that you want to see in this particular one. If you want to look at, say, beds available, if you want to look at occupied beds, and if you look at this sum of occupied beds, I mean, this looks okay, but this one here is actually, if you go to the value field setting, you could say, well, what I really want to do is control that number. I don't want to see all those decimal points. I just want to clean it up this way. So now I've got my occupied beds, got my bed available. There's another wonderful feature on a pivot table for fields. So if I go to calculated fields, I can say, well, what is my occupancy percent as an example? And then I could just go in here, backspace a little bit, insert a field. I'd say I'd find my occupied beds. There we go. Insert that, divided by the available beds. Insert so I'm done. I click OK. And here's my occupancy percentage. Again, all I do is I want to go to this value field. I want to actually look at the display of this information. Let's leave it at 1 decimal percentage like that. Click OK. And here I have it. Now let's say that I want to look at hospitals in another county. I look at Contra Costa County. Here's the hospitals in Contra Costa County and the percentage. Here's El Dorado County. Any county that I want to look at, that's one way. So if I put in all my counties there, let's say that I want to actually compare a few different hospitals. So I want to compare Alameda County with Arrowhead, regional, with Beverly Hospital. You just keep picking your hospitals like this, and there you go. You've got all the hospital comparison data that you want, and I can keep adding all those fields over to the right. Now what if I take this and I move it underneath, something like that. If I put the facility names up here, right, then I can keep adding data on here. What if I just added the big 5? And so you should go to a tutorial. YouTube has tutorials on pivot tables. Anybody that works with data, you should get comfortable with this, because once you learn it, it'll just change your life. I like to put a little title on there, Pivot GS, give it a name. I've already got the field names down here, and so what I'm going to do now is just go to one that's a little bit more of, let's see here, that one. So I've actually got the data here. This is exactly the same data that I had before. And if we go into a trend here, so I just want to tell you what I've done. I put a little it's called a, let me just look at this. It's called a slicer. So you can actually use any kind of slicer you want. If you want to put in, like the year, you just click on there, and I could say, let's put that slicer over here. So if I want to just look at 1 year, I could do that. And if I want to look at all the years together, I can look at that. I could click on 1 year and use a control shift and click this. So I got 3-year trends going here. Let's just keep it at a 5-year trend. This happens to be Stanford University information. So let's just see what we have possible here. I'm looking at one hospital. It's 455 beds available, 370. If we go to 2012, 386 occupied beds, 83% occupancy. They use adjusted occupied beds based on outpatient revenues, 686. Now these are inpatient day totals, discharge totals. If I divided the patient days by discharges, I could get the average length of stay. The yellow here, these are calculations that I've done from this pivot table tool, this little calculated field here. I've calculated total surgeries or inpatient and outpatient. Chapter 1 is salary and benefits. Percent productivity FTEs. I've just put in a bunch of calculations here, and they're all just in yellow. So once you put them into the pivot table, they work for all of these raw data totals that California has made available to me. And so if I look at Sutter, Auburn Hospital, if I put it St. Helena Hospital, I just compare this. I just am able to look at any hospital that that I want just by clicking a slicer. So what else do we have here? We've got surgery cases, inpatient, outpatient. I've added those up, so I have a total here. They actually have the minutes of inpatient, outpatient. I can look at minutes per surgery case. Here I've got Stanford doesn't have any births, but I've got raw data, natural births, C-sections. I can do C-section rates. I can look at assets and liabilities. I'm kind of looking at this one here, by the way, as a trend. Stanford went from 2 billion in assets, 2.7, and then all of a sudden they jumped up by $1 billion, and I'm looking at that and I'm saying, do you think that's really possible? Did they get some big endowment? I'm not too sure about those numbers, but when you're looking at them in trends, they will self-correct. That's the value of making your data open and transparent. The productivity FTEs I calculated based on the productive hours. Usually we don't bother looking at the productive hours because it's not a humanly conceivable kind of numbers. Who cares about 11,619,000 hours? Divide that by 2080, we get 5586 as our productive FTEs, our staff levels. And now that makes sense, and we could look at our FTEs by occupied bed or adjusted occupied bed. I think that's what we have here. Productive FTEs per adjusted occupied beds. That actually is a calculated field. So I just click on that, go to home, and I just color that just to keep straight, what we have calculated, what we have in raw data. I took our expense and our salary and I created that as a total Chapter 1 expense, for example. If this is our total, then I can subtract Chapter 1 from the total and I get my Chapter 2 other operating expenses. My supply expenses are here. I can do percentages. I can do any kind of calculations, but fundamentally what we have built here is a wonderful little diagram. If we go here, one little printout of our 5-year trend of one hospital, key data for an executive summary profile. And you can see how easy it is, and I just am recommending that any licensure authority should actually be getting this data. In the U.S., it's a cost report that's required by Medicare, Medi-Cal. A lot of proprietary databases downloaded, but none of them do your executive profiles for you. And frankly, every licensure authority in the U.S. it happens to be the states that could do this kind of little data set. Here in the UAE, it could be the Health Authority of Abu Dhabi. It could be the UAE. They're half the size of California, so it would be quite easy for them to collect all this data. And once they've got this data available, they can collect it annually on a nice, they could collect it on a monthly basis. But annually, they report it up to the World Health Organization. It'd be so easy to provide this information to WHO. And once you master this, all of this data in the hospital is, just part of routine operations. So they could actually use this as their presentation to the board if they had it on monthly trend data. Even the internal hospital is doing this already for the most part, certainly, any normal hospital. So reporting it upward to the health authorities, to the licensure agencies is really not any additional work for them at all. And it really does help you to understand the healthcare industry. Now, there is also a nice little thing. If you go here to compare, what I can do here is I deselect all the hospitals, and I could just click here and say, look at Alameda County. So just like that, I have all of this data, the executive summary. I'm comparing all of the hospitals in the county, and by adding this data up for the counties, I actually now am able to provide what we'd call community information. If you're going to have a healthy community, you have to know what is the admission to hospital rate, what's the ER rate, what's the volumes of visits to hospital. And if you're collecting all of this data into a proper data set at the community level, then you can begin to integrate all the stakeholders to do what's necessary, whether it's in businesses, in education, neighborhoods. The public health department can actually use this data very nicely, and I just think every public health director would absolutely want to have this kind of data. They measure it to their population census information, and in the U.S. they're required to do what's called a community health needs assessment. There's a whole board that is now developed accreditation of community health needs assessments. You can go to that separately. Maybe we'll do that in another talk. But if we just go back to our little website here, I've actually taken this information. When I was with Saha, I didn't actually know how these pivot tables work so easily, and so I used to do this side by side and just add them up with formulas on the right. Well, now, frankly, I could give you an example of how easy it is to compare all these hospitals and maintain these trends. So basically the recommendations are every hospital ought to be doing their executive summaries, collect their raw data, and then work with pivot tables, master that internal data, do their monthly trends, just teach the main areas how to do pivot tables like HR, finance, medical records, supply, who else do we have, revenue, center. Publish these statistics on your websites. If you're a hospital, make them available to the public. Let people want to know, and it just helps. You're going to have to share them anyway. You should be sharing them with the authorities. So just put your monthly stats up there and let people see the kind of activity that you have. You should be, as a hospital, you should be establishing a consortium with your public health authorities and licensure and submit this data together and just be helping one another to share data and work together so you can have efficient, productive, proper care. The annual collection of the big 5 data sets, that's your central core objective. Create one collection point. update annually. It should be downloadable from this pivot table to anybody that wants it. And you should, if you're a hospital, you should download it and make it uploadable, or do a hot link into that licensure source where the data table is done. It's so easy. Make it easy for people, and apply these principles to your quality and other indicator sets. You can do the same thing so easily with all the clinic indicators. We'd like the Joint Commission to use these pivot tables and do comparative pivot tables with all of the data that they have all over the world, for that matter. Claims to insurance companies and for revenue, for collecting their revenue, are a great resource for pivot tables and all kinds of information. Birth and death registers, generally the public health department should make these pivot tables available, so we understand a lot more of the information pertaining to these births and deaths that happen in our communities. It helps the hospital kind of be part of all this, the community. And we talked about licensure data registers. Also, the public health department should be having population data sets. That's kind of another video as well. But I can tell you most places are very, very difficult to get the population by city, by state, community, that really the hospital would like to know about, so we can look at rates of death rates and incident rates per 1,000 people, that kind of thing, for planning. So that's it. My name is George Swan. If you have any information about this that would add to it, send me. If you have questions, if you want to have a little workshop on it, just call me, and I think we'll find a way to make this all happen. Thank you very much.